we'll get started here. Thank you all so much for coming to a talk about confidence intervals on a Friday morning. Honestly, as soon as we made this didactic, I was like, they are definitely going to schedule us for Friday morning, and that happened. So I'm really sincerely happy that you guys are all here with us. All right, so this is a very, very quick 20-minute primer on the reasons that a lot of interpretations that we have kind of commonly on like what a 95% confidence interval is often may not be correct, and kind of how that relates to brief introduction to the other area of stats that you may or may not know about, but Bayesian stats, which use a different type of interval that ironically is very much like a lot of the misconceptions about confidence intervals, that has a lot of the properties that we ascribe to confidence intervals that aren't actually true. I'm Nicholas Harrison. I'm a cardiovascular researcher from Indiana University, and then Rob and Jason.
Steve.
Or Rob and Stephen can.
I'm Stephen Miller. I'm out of Virginia Commonwealth University.
I'm Rob Ehrman. I'm from Wayne State.
All right. These are disclosures. I don't think any are particularly related. None of us have honoraria from, I don't even know who that would be from.
Big statistics.
Big statistics. The Thomas Pace Foundation. So yeah, that is kind of what I led with. Define confidence versus credible intervals, kind of go into some of the myths, and then understand some of the limitations. All right, so why do I care? Why did we submit this talk in the first place? And I think that whether or not you are a stats person or not, I feel like in 2023, the vast majority of probably just physicians, period, but certainly academic physicians, understand that p-values aren't perfect, that there are limitations to them. Like, we have done a really good job in the stats community, kind of broadcasting to anyone with an MD or a DO after their name about the pitfalls of p-values. What we have not done a very good job of is educating people on the fact that it's basically the same stats as a confidence interval. And so we tell people, well, and I feel like some very prestigious journals in particular, which will go unnamed, often even say in their author instructions, well, don't give us p-values. We want confidence intervals instead, which is good and is good advice. But I think it often leads to a sort of misconception that confidence intervals are solving a lot of problems of p-values and solving a lot of problems in general that they really aren't. And just knowing those limitations is important. All right, so most of this is going to be interactive, true, false, and you can just raise your hand for true or shout out. How about shout out true? And we're going to go through kind of one by one. So true or false? 95% confidence interval means that you are 95% confident that the true value lies between these bounds. Who says true? Okay. There is a 95% probability the true value is within the interval. It's actually false. We'll explain in a sec. And it's false on a it's something that is both a technicality and incredibly important in a weird way, and we're going to get to why that is. All right, true or false? Confidence intervals are intrinsic extensions of the same statistic as the p-value. I kind of already, said this. And suffer many of the same limitations. True. Oh, this is where you insert a friendly argument.
Oh, yeah.
It says Rob Ehrman inserts friendly argument here.
I do have a friendly argument. So all of what he said, I agree, would be technically true, but I would also throw out there that it kind of doesn't matter, right? It's sort of people talk about the problems with p-values, and I agree that sort of by definition confidence intervals are extensions of p-values, And a lot of ink has been spilled talking about how people don't understand the actual definition. But in some ways, I would argue that it actually doesn't matter. There's nothing really wrong with p-values or confidence intervals as long as you understand what they are and what they are not. They don't represent truth in the universe, like the results of this study are absolutely true and you therefore must absolutely do this. It gives you some idea of a point estimate. You need an effect size to go with it, and then it's a measure of uncertainty. And as long as you kind of understand that, I think that there's less problems with p-values and confidence intervals than other people think, including some people on this stage.
Yeah. No, you and I are both closer in alignment than I think we've at times argued about, but.
Yeah, the interpretation, and I think it's how, we all have been in the journal club, and everybody's spouting off the statistical significance, look at the p-value, look at our confidence intervals, and it's getting that degree of uncertainty and being able to feel comfortable with the interpretation. And a lot of the suffering that p-value had interpreting those values and what it means, null hypothesis testing, all the confusion that goes into it, there's still some of that around confidence intervals, hence what we're talking about here.
All right, who thinks this is true? Main difference between a confidence interval and p-value is that a confidence interval restates the information, the p-value, on a scale of the thing being estimated, where the thing being estimated could be one of these various things. Could be a mean, could be an odds ratio, could be a risk ratio. Who says true? No one. It is true. That is fundamentally the difference. So it is a measure of uncertainty. But it's a measure of uncertainty that is taking the same underlying statistics underlying the p-value and then just restating it in an interval that is really just a way of saying you're giving a measure of uncertainty that is now on the scale of whatever you're estimating rather than some percent, which is what the p-value essentially is in this case. All right, here's one that I think a lot of people get surprised about. If an odds ratio is reported as 0.25, and the confidence interval is somehow, and this may not be mathematically possible depending on how you're getting this, but 0.03 to 1.01. So it's quote unquote almost significant. Is it more likely the true value is less than 1 than greater than 1, since most of that confidence interval is? No, it's false. If you did 1,000 studies simultaneously in the same population, essentially in some scenario where there is 1,000 yous in the multiverse, all doing them at the same time for a single intervention in a specific condition, and all 1,000 were done at the same site, same time, 950 of the studies would have confidence intervals which contain the true value. Who thinks that is the actual, or close to the actual definition of what a confidence interval is telling you? It's true. Yeah.
Strong work.
So it's a really convoluted way of thinking of things, and the convolution is in some ways the point. If you think about it, I mean, it is truly invoking a hypothetical, right? It's invoking a scenario that can't actually occur in real life. And you can make some arguments about that, and in certain other fields, it's more likely or closer to get to that hypothetical, where you're doing 1,000 studies on the same thing at the same time with the same sampling and no heterogeneity in the underlying population from one to the other. But in medicine, that's hard. Especially clinical research in particular. In basic science, I think you can do that more. But in clinical research, that doesn't really happen.
And I think I have a friendly argument to insert here as well, which would be, I mean, this is more or less the definition of what a confidence interval is. And but in the end, I would argue that it actually doesn't matter that that's convoluted and complicated, as long as you understand what it is and what it is not. And and relying too much on the technical definition and why it's not what we think it is sort of the same mindless adherence to like technical definitions that people who hate p-values talk about. But in general, right, you should look at a study, you should judge the merits of the study based on the methodology, your sort of pretest probability, like does this have face validity? Do you think this study is done well in the right kind of population? Is answering the question that they set out to answer. And then you look at the statistical testing that they've done, and you get an effect size, you get a p-value, and you get some confidence intervals. And so, right, as a general idea, p-value tells you sort of statistical significance, it's arbitrary, but again, you interpret it in the context of everything else you've read in the study. You have an effect size, and then you have a measure of uncertainty, which is the confidence interval. Really wide, not very precise, very narrow, a little bit more precise. Again, a very narrow confidence interval with a very small p-value doesn't make the study result true. It doesn't necessarily mean it's truth in the universe. This is the same thing. The idea, I think, which is important is to, again, understand that these are sort of guideposts, the p-value, the confidence intervals that help you, that give you some information about interpreting the study results, but nothing, there's no single thing, even Bayesian credible intervals, and they have a more intuitive interpretation, but these don't actually tell you what is like true or not true. You have to put everything together. There's no like simple shortcut to again finding truth in the universe, yes or no.
Yeah, I think maybe another way of saying that, if you agree with this, I think you would, because we've talked about this probably more than any two individuals should talk about this. But there is something ironically qualitative to measures of uncertainty and measures of precision. I agree with Rob that like we're focusing on this very specific definition here, not to say like, okay, you need to reframe all your thinking to apply that very technical definition to how you're thinking about this forward. It's actually kind of the opposite. It's more understanding that when the rubber hits the road, you're really just sort of getting a general idea of how precise a study's estimate is. And it is much more of, yeah, it's somewhat precise, or it's very precise, or it's not very precise. And there's, I mean, sure, you could probably make up, because people love to make benchmarks and guideposts for things. You probably could, but it's probably better just to sort of reframe thinking on confidence as more of a sort of, yeah, it's a measure of precision. It's one measure. Is that fair? I'm going to skip past this because this is actually a little more than we necessarily have time to go into right now. All right, so we kind of already spoiled this a little bit, but did you know? How many people knew there's two different families of statistics? Nice, thank you. How many people knew that most of the time when we say stats, we're really just talking about one of them? Because despite there being two families of statistics, particularly in medicine, we have for a very long time, and even to this day, mostly just used one, and that's frequentist stats. The p-value, the confidence interval, they're all based on the idea of the fundamental frequentist framework. Bayesian stats are a little bit more computationally, or I should say a lot more computationally demanding, where it's been more in relatively recent history that lots of people can do Bayesian stats with like fairly available technology they have on hand, like on a laptop or even a desktop. So Bayesian stats, how does it work? Well, I think a lot more people are familiar with Bayes' theorem in the context of, the clinical diagnostic framework in particular. And it's not really a different framework, it's just sort of a different application. But you're taking prior data in, or expectations of prior data and how that data is distributed. You're gathering more data from a new study, and then you're updating your prior expectation to a post-test probability or post-test expectation. So you have some knowledge of what's going on, you get more data, you refine it, and you come out with ostensibly better, more precise, and more accurate estimations of what's going on. And the key here is that when we're talking about accuracy, what we're really saying is closer to the true population value, which you can never actually know, right? The only way you can know the population value of anything, whether you're saying what's the rate of MACE in patients discharged from the ED after 2 high-sensitivity troponins. We have estimates of those. And we've actually gotten pretty close and are pretty confident to what the true values of those things are, because we have very, very large and close to population-based data sets. But even then, even in that kind of problem where we have, those studies are thousands and thousands of patients, you're still not getting the true population value, because you would literally have to test all of the people. Did you want to go over this, Stephen? This one?
Sure. Yeah, put that back up for a second. So this is the,
Or you put this one in?
yeah. So,
I think and you feel free to chime in. So this is taken from a 2021 article looking at calcium given IV or IO and a ROSC or cardiac arrest patients. And what's interesting about this, and I think it fits to a lot of where we are at, is this was done with a primary analysis that was frequentist, p-values and everything, but they did a Bayesian analysis where they implemented different priors, and you'll see this in research if you look at any of the more recent studies that are putting Bayesian methods into place. They put these different priors. So there's a strong skeptical prior, so my information and knowledge ahead of time, I have very little of it, and I think that calcium is not going to be effective, all the way to a pessimistic prior and or optimistic prior, where I think that calcium will have a more substantial effect. And then the priors or distribution are the dotted lines in there, and so you can see the intervals of where they create, and then you can see it has its impact on the posterior, and the posterior are the shaded regions, with the dark region being calcium having a negative consequence, and the light region having a positive consequence. And so as these priors change, this is a good visual representation of changing your posterior, your primary outcome analysis one way or to another, to give you a little bit more knowledge, a little bit more feel of what your intervention has done and where it leads to. And so I think that's one of the reasons we put it in here, but
yeah, no, I agree, and that's one of the real strengths of a Bayesian analytic approach, is that you can set your prior probability that in this case calcium is useful, and you can test it based on the data that you've actually observed, and then you get a posterior distribution of the likelihood of a benefit, and that gives you information that's just not available in the frequentist framework. And these shaded areas are the Bayesian credible intervals, and they have the intuitive interpretation of the probability that the true effect lies within that interval. And so the taller areas are essentially where more of your data lies, and you're more likely to have that be your true outcome. But again, this is where I kind of get back to the idea of understanding confidence intervals versus credible intervals. It's not, they're separate things. A Bayesian analytic framework gives you some information that a frequentist one doesn't, but that's, to me, that's a separate thing from the confidence interval and understanding what it is. And so you have to, again, just sort of understand all of these things. I don't know that the Bayesian approach necessarily gets you the answer of truth in the universe. It gives you sort of a range of interpretations or possible interpretations of the data, of the results of your study, but it's not, again, absolutely this must be true. And so again, you have to just sort of understand the strengths and the weaknesses of the varied approaches and kind of decide for yourself based on your knowledge whether or not you believe the study results.
Yeah.
And I think one thing is it's all about assumptions, right? All statistics has your assumptions in it. Your frequentists still put your null hypothesis assumption that is in place. And here we're taking my prior knowledge that I'm going to interject into this, and you could differ in what you think that prior knowledge should be. So we could come at it in two different ways, but we could have at least a discussion. It's up front, it's out there, and it allows you as the reader to take a look and interpret, what I've put in place. So I think that at least puts it all on the table as opposed to frequentist, which gets a little bit, again, as long as you're looking at them and interpreting them the appropriate way, which I would maybe argue is not the global case, but it's definitely, it allows you to put it all out there in this context.
Yeah, I think that's such a good point, is that, I mean, the nice thing about the Bayesian approach is that the assumptions, just as you said, they are all out there, and you can test, essentially, you can test think of it as a sensitivity analysis, or at least analogous to a sensitivity analysis. It's not the exact same thing, but where you can say, okay, if I changed my assumptions, how would that change my results? And would it change it in a way in which I would take my main results and I would apply a much higher degree of skepticism to whether I believe them or not? And these are things that you can, that are both out there and that you have a lot more flexibility to test on your own. Most of the assumptions underlying frequentist statistics are unfortunately kind of baked in already. And the only way that you can there are a lot of hard assumptions that come from the population itself that are a little bit relaxed. And it doesn't mean that they're fully relaxed, because that's actually an argument I've seen out there that I would not advocate for. But they're not fully relaxed in a Bayesian framework, but they're somewhat relaxed in certain ways where you can get around that.
Yeah, if I can ask a question. This is hard enough for me to understand. How do you guys think all of this stuff translates into a discussion at the bedside in terms of shared decision making?
So, so actually, just looking at this visual, I would ask you, if you look at that visual, would you feel good about giving calcium to patients?
No.
Just out of all of these prior knowledge that you've put in, and I've run this analysis just on this one visual, I need no other statistics out there. On this one visual, I can look at that and I can feel, at least in my practice, I don't think, and this is the conclusion of the authors as well, the calcium was not beneficial versus placebo. Yeah. Most of that area, even in the most optimistic priors, is shaded dark.
You got more than half dark gray than light gray in every circumstance and every way you slice it.
Yeah, I think the visual ways, there's a great visual for TPA and acute ischemic stroke that has 100 stick figures, and this is how many get better, this is how many get worse, this is how many die, and these are all the other people that don't have not better, not worse. So converting all of the stuff, not including the slide, into a visual, I think could be really useful at the bedside.
Yeah, and I think this lends it more to it. And the reason is, so a credible interval, the Bayesian interval, is doing what I think a lot of times we mistake confidence intervals for doing. So in a credible interval, there is a 95% probability that the true value is within that interval, assuming you've met the other assumptions. But that's not, as we mentioned, that's not the case for a confidence interval. So at the bedside, you can't go to your patient and say, you know, studies have estimated that there's a 20% increased risk of having, you know, having MI if we don't give you this drug. And that's somewhere between a 5 to, there's a 95% chance that it's between a 5 to 30% risk.
I think it's an important question. That I would just interject and say that it's a great question. I think that's like a next level question in the sense of we have to understand how to interpret test results ourselves, and then the next step is figuring out how to do, like you said, the TPA diagram is very easy to understand. But before we can get to something like that, and people have talked a lot about the TPA issues, clinicians, researchers, I think really all physicians should kind of understand this so that you can interpret those studies and then come up with a way to effectively communicate at the bedside. I know we're kind of out of time, but does anybody else have any questions?
So, first of all, this is not my field, but what if I threw out this to challenge you? What if I said that, I think the Bayesian, you're using prior knowledge to improve, but if you had a really large meta-analysis, wouldn't the gold standard just be a frequentist approach with a meta-analysis where you don't need a prior, you're just pooling all the data, and isn't that the gold standard? Is there a role for a Bayesian analysis once you've already done a big pool of meta-analysis? Why do you need priors?
Well, so again, the meta-analysis, it's a good question. And as you get to larger and larger scale, the central limit theorem kicks in and ultimately doesn't make a huge difference. But ultimately, a meta-analysis is still lots and lots of samples, and this is actually one of the problems with doing meta-analyses. Not one of the problems, but one of the severe challenges is, estimating heterogeneity between studies, and that's fundamentally what can make or break a meta-analysis, and it is very hard to really tell how much heterogeneity is between studies. Cochrane used to, the I statistic was used quite a lot. Cochrane now says, we have more people who have studied meta-analysis for their entire life, and now they say maybe we probably shouldn't use the I statistic as like a one-size-fits-all. And now we're kind of back, at least the last time I authored a Cochrane review, we're back at a place where the guidance on how to assess for heterogeneity is kind of murky, I think.
And it kind of comes back to my answer to your question would be, or a different way to think about it would be, if all of those studies that went into the meta-analysis sort of met that, the criteria of sort of the definition of a confidence interval in that they were very similarly done in a fairly uniform population under pretty similar circumstances, then the answer to your question, that's in some ways is sort of the foundation of frequentist statistics, is you get a large enough population representative sample, then you wouldn't necessarily need to do a Bayesian approach, because you could have enough patients that are enough in your study that were similar enough that you could kind of get, quote, the answer. The problem becomes the studies are just not the same. They're done in different places. They're done in slightly different time periods. There's, secular trends in medicine where, stroke care is different now from how it was, 10 years ago, 20 years ago. And that those same sort of little differences kind of trickle out into almost effects that are kind of too small to quantify in individual studies. And so when you put all that stuff together, you in fact oftentimes don't actually you're not getting necessarily closer to truth in the universe. So.
Yeah, in some way, what the question you asked is the central issue here. I mean, it is a tremendous question, because ultimately it comes down to, is this something that you can pool where you're confident that these were all the same things? And I mean, that's a whole other talk, but I think, so for instance, I do heart failure research. Heart failure is a clinical syndrome. So there's no gold standard for diagnosing someone with heart failure in the same way that there is for acute coronary syndrome. At least not a pathologic gold standard. So things like that are clinical syndromes, those studies tend to have a lot more heterogeneity in the populations and end up running afoul of some of these problems that then violate many of the frequentist assumptions. All right. Thank you so much, guys. If you have any other questions, please.